Okay, good morning. My name's James Stanger, and today I'd like to talk about an article recently published in Reproductive Biomedicine Online by the Canadian Fertility and Andrology Society. These are guidelines on frozen embryo transfers. And this is guidelines, as the author said, provides evidence-based recommendations drawn exclusively from recent randomized control trials for the clinical management of frozen embryo transfers called FET. And here's the URL to that document. It's open access, so anyone can read it. And the authors are given an overview of the paper, which they say in Canada, the incidence of freeze-all cycles has increased from 24 to 78% over the last 10 years. While a freeze-all strategy can be a pivotal tool for the prevention of ovarian hyperstimulation syndrome, or OHSS, the available data do not support its routine use for improving live birth rates, reducing pregnancy loss rates, or enhancing obstetric outcomes in the general IVF population. Similarly, ovulatory FET cycles do not offer advantages over artificial FET cycles for live birth or pregnancy loss, or current evidence remains conflicting for obstetric and perinatal outcomes. The route of progesterone administration in artificial FET cycles does not significantly affect live birth or pregnancy loss rates. FET approaches should be individualized based on patient characteristics. My morning coffee. And clinical context, and further research is necessary to optimize outcomes and inform best practice. Oh, you can hang up the video now because you've basically got all the information, but let's just go back and look at how they've done it. So they said from 2013 to 2023, the incidence of freeze-all cycles in Canada has increased from 24 to 78%, due largely to the increased use of pre-implantation genetic testing for euploidy, PGT-A, which accounts for almost 50% of all freeze-all cycles. But also ovarian hyperstimulation syndrome risk prevention and improvements in vitrification techniques also account for the rise of freeze-all cycles. This is where there's a belief that FET, vitrified embryos, when warmed and transferred, have a higher pregnancy rate than fresh transfers, but the data is still very much out on that. But I'd just like to make a point. Actually, something that needs to be said about the extent of PGT-A is dominating IVF practice. One consequence of PGT-A is that by definition, all the FETs involve the transfer of euploid embryos, that is, in the right number of chromosomes. So when you see data comparing fresh and frozen ETs, you are largely comparing the transfer of unselected embryos in terms of the genetics just only on their appearance against a mixture of unselected and selected euploid embryos. And spoiler alert, there's no difference. Excuse me. Many studies previously have included observational and control studies that may cause increased heterogeneity and give you an incorrect assessment. The guidelines in this paper exclusively use randomized controlled trials to compare FETs with fresh transfers and to evaluate which endometrial preparation protocols optimize live births and obstetric outcomes. The data presented is just a series of forest plots. It's pretty boring, really, but the information is really important. And if you're new to this form of meta-analysis, a brief review of how to understand the forest plot format is in the next slide. And here it is. This is something taken from the internet. This is a forest plot that uses 7 studies to show that corticosteroids can hasten lung development in the pregnancies where babies like to be born. And this is how the data is presented. It's a series of studies with 2 sets of data, one with corticosteroids and one placebo. It might be fresh transfers and frozen transfers. And then this is the number of deaths in the study. And then there's an odds ratio. And then here is a graphical representation. And there are 2 things that are important. One is the position of the square, which is the mean, and the width and the length of the horizontal line, which is how much the confidence you have in that mean. So when you have a small horizontal line, means the data is fairly concise and you have a lot of faith in that. Where the data has got a very long line, there's a very large confidence limits and the data has less confidence in it. And also the size of the square also indicates how much that data set has contributed to the overall mean. So it always has a horizontal line, which is the odds ratio, and a vertical line, which is the point of which there is no difference between one side or the other. It's either 0 or 1 normally. And it has a series of individual publications and then there is a diamond at the end, which is the summary of the data. And if the argument is that if the diamond crosses this vertical line, then usually there is insufficient data to say there is an effect. But where you have the diamond on one side or the other, then you will conclude from the meta-analysis of all these publications that there is an effect. And in this case, as we say here, the odds ratio of one indicates no effect. Studies with confidence limits, the horizontal lines crossing one vertical lines, indicates the data is inconclusive. Powerful studies here where there are more participants have narrow or shorter confidence limits like this one here. A study with an odds ratio of 1 and a very narrow confidence limit would indicate no significant difference, such as like this one here. However, the summary of the Auckland study have narrow confidence limits intervals that do not cross the vertical line of 1, indicating these studies would be judged statistically significant. In other words, giving corticosteroids to babies likely to be born prematurely is likely to result in fewer deaths. And so now that you fully understand how forest plots work, let's just jump straight into it. As I said, this is taken straight from the open access article in RBM online, and because it's open access, I'm just presenting it, but they are all forest plots with different questions which the forest plot attempts to answer. And the first and most important one is, does freezing all reduce the incidence of air and hyperstimulation syndrome? And the answer is yes. So most of these studies here are definitely showing that freezing all the embryos and doing a fresh transfer is infinitely better than doing a fresh transfer and running the risk of ovarian hyperstimulation. So here, this is the diamond down here, clearly on one side indicating it favours frozen embryo transfers. Okay, the next question is, does freeze-all improve the live birth rate on the first transfer? That is the first transfer, either for a fresh one or the first FET. And the answer is somewhat equivocal. That is, in fact, there's no difference. You see all the means and confidence limits are all fairly close and scattered directly around the line 1, indicating a p-value of 0.07. That is, there is no significant difference in the live birth rate between putting back a fresh embryo as a live transfer and running the risk of ovarian hyperstimulation, and putting back the first embryo as a frozen. That is, embryo freezing does not compromise the outcome. So does freeze-all affect the risk of pregnancy loss in the first transfer? That is, does vitrification of an embryo cause more pregnancy loss? And the answer is clearly no. So pregnancy loss rates vary from 0 to 22% in FETs and 3 to 21% in fresh FETs, without any significant difference between the groups. And this is interesting because if half of the cases are performed for PGT analysis, then half of the frozen transfers will be euploid. And one of the advantages of doing PGT testing euploid transfer is a halving of the pregnancy loss rate. And here we can see that, in fact, it makes no difference. So casting some doubt about the value of PGT-A in reducing miscarriage rates. Sorry, just a bit of a truck working outside. I'll pass on. Next question is, does FET increase gestational diabetes? Answer a bit more variable, but the answer is no. There is no difference in gestational diabetes between fresh and frozen transfers. Next one, does it increase gestational hypertension? Now, the reason this is, there's been quite a lot of articles, and I've already done a couple of videos on the risk of preeclampsia associated with ovum donation and surrogacy. And some people suggest this is because they're due to frozen transfers rather than an allogenic transfer. So in this case, you ask the question, is there any difference in gestational hypertension? And the answer is no, p-value of 0.92. So in fact, there is no difference at all in the risk of gestational hypertension whether the pregnancy was from a fresh or frozen transfer. Does it increase hypertensive disorders of pregnancy? And there's quite a few of these. And the answer here is that p-value of 0.03, and even though a lot of these studies cross the vertical line, overall, you can see here that the answer, does it increase hypertensive disorder? It favours FET. That is, however, FET was associated with an increased risk for hypertensive disorders pregnancy. So in this case, there's 108 cases of hypertensive disorder out of 3,500 compared to 69 out of 3,500. So one of the concerns about using FET is an increased risk of hypertensive disorders. And one of the main ones people have been looking at is preeclampsia, but there is a range of other ones, and I'm not really a clinician, and I'm not really in a position to talk widely on it, except report the data. And here the answer is somewhat equivocal. P-value of 0.13, so it's from 4, it's starting to fall. There is a tendency towards preeclampsia in FET cycles, but with these cases, it is not significantly different. And you can see the summary here, just crossing the vertical line. But you would think that there is something here that is preeclampsia 69 over 361 compared to 41 out of 370. So there is something there, but at the moment it's maybe there's a lot of other variables. Does it increase preterm births? And the answer, fresh and frozen, the answer P.7. And the answer, except for this one study, the answer is no. So there's no difference in preterm births between fresh and frozen transfers. What about the babies being large for gestational age? Does FETs increase large gestational age? And there's been some suggestion of that. And the answer is 0.05. The answer is no. But you can see there's been quite a few studies, including this one here, of 825 cases, where there is strong data to suggest that babies born from FET may be heavier for their gestational age. But really, the data is equivocal, and clearly there's a lot of other cofactors influencing this, which you would think randomized control studies would get rid of. And so the answer is no, but there's something about that we should be careful of. Does FET result in small gestational age? And here the answer is no, because it looks very strong. 0.02 is that pregnancies which are small for their gestational age, that's growing slower. 49 out of 2,000 for frozen, 84 out of fresh. So there's a suggestion here that fresh transfers are associated with increased rates of small gestational age. And then we move on to the management of FET cycles. So this is how you actually control an artificial cycle. And one question is, does pituitary downregulation improve the live birth rate before you start the hormone treatment? The answer is no. Does it risk pregnancy loss? And the answer is no. Do ovulatory FET cycles improve live birth rates compared to artificial cycles? And the answer is no. That is that if you do FET cycles, and whether it's a corpus luteum or with artificial hormone gestation cycle, the live birth rate is just very similar. However, the question is, do ovulatory FET cycles affect the risk of pregnancy loss compared to artificial cycles? And the answer is almost certain. So they're 0.08. The authors say pregnancy loss rates were also similar in both groups, 9% to 11%. But if you look at the statistics, there is just a marginally lower pregnancy loss rate in corpus luteum cycles than artificial ones. And so the data is, there is suggestion there is more pregnancy loss, but over the whole number of studies, the answer is only just no, only just no. The 0.08 is, that's an arbitrary, 0.05. 0.08 to me tells you there's something going on. That is, if you have a FET transfer in artificial cycle, there is an increased likelihood, but not necessarily a highly significant one, you will lose your pregnancy. I make the point here, I've just done 2 videos on preeclampsia and IVF. It was born out of a series of studies looking at oocyte donation, where there's a higher risk of preeclampsia and oocyte donation. And one of the questions was whether it was an artificial or natural cycles, and I've done 2 videos on that. But the authors have gone back and made a comment about this, and they've said that the recent review in 2003, which I referred to here, that included 30 observational and retrospective studies of 56,000 ovulatory and 57,000 artificial ones, suggested that ovulatory cycles have improved obstetric outcomes. However, this review did not include any of the randomized trials, and thus may reflect bias in which patients were offered ovulatory against artificial cycles. And they now had this, in this study, they quote as a sub thing, which is found in the supplementary notes, that there are 3 randomized control studies, which they cite 2, that have compared ovulatory and artificial cycles, and that did not corroborate any of the obstetric findings in the systematic review. So in this case, this is the thing for preeclampsia. And in this case, they found 15 out of 750 preeclampsia events with corpus luteum compared to 8. So this randomized control study offers a different review, different perspective to my other two YouTube videos. But I'd like to make a point that Bellevue, is the highlights of his paper. He does say the risk of preeclampsia may be increased in artificial cycles. Artificial cycles associated lower clinical pregnancy rate and live birth rates. Artificial cycles exhibit a higher incidence of trimester bleeding, and progesterone concentrations are lower in artificial cycles. So even though he's published a randomized control study suggesting that the incidence of preeclampsia, well, this is actually showing preeclampsia, which is higher in FETs rather than enrichment, is basically quite contradictory to what the authors are saying here. But I'll let the authors read those papers and move on. Comparing intramuscular progesterone to vaginal progesterone, does that affect live birth? P of value 0.05. The answer is no. Comparing intramuscular progesterone to oral progesterone, does it affect live birth rate? The answer is no. Does comparing oral progesterone to vaginal progesterone affect live birth rates? And the answer is no. So in summary, the authors make this summary statement. Freeze-all strategy should be used in patients at risk for ovarian hyperstimulation syndrome. A freeze-all strategy should not be used to improve live birth rates because it doesn't. That is, you shouldn't freeze all the eggs, embryos, and put them back FET under the misguided belief that FET pregnancy rates are higher than fresh ones. A freeze-all strategy should not be used to reduce pregnancy loss rate. I think that that's somewhat equivocal. There's still some questions about this one. And a freeze-all strategy should not be used to improve obstetric outcomes because I still think there's some doubt. FET with routine pituitary downregulation agonist should not be used to increase live birth rates. And FET with routine pituitary downregulation with agonist should not be used to decrease pregnancy loss. So compared to artificial cycles, the authors state ovulatory FET cycles do not increase live birth rates with a low grade of confidence. Ovulatory FET cycles do not decrease the pregnancy loss with a low grade of confidence. Ovulatory FET cycles do not decrease the risk of obstetrics and perinatal complication with a low grade of confidence. And the route of progesterone administration does not impact live birth or pregnancy loss rates in artificial cycles, a low grade of confidence. So the authors then concluded, and I think this is an excellent paper, and everyone should read that to be confident about doing artificial cycles or natural cycles with corpus luteum. These guidelines provide evidence-based recommendations for the clinical management of FET cycles based on available randomized control trials published since 2014. While freeze-all strategies is a very important tool for the prevention of ovarian hyperstimulation syndrome, the available data does not support its routine use for improving live birth rates, reducing pregnancy loss rates, or enhancing obstetric outcomes in the general IVF population. Ovulatory FET cycles do not offer advantages over artificial cycles in terms of live birth or pregnancy loss rates, but the current evidence remains conflicting regarding obstetric and perinatal. It is all about preeclampsia and associated hypertension issues. That's all it is. And they're real. And I think, I won't say any more about it because I'm not a clinician. Furthermore, progesterone administration routes and artificial cycles do not significantly affect live birth rates. The decision between a fresh and frozen transfer, as well as the choice of endometrial preparation protocols for FET, sometimes this is a mouthful, should be individualized based on the patient's clinical presentation, safety consideration, protocol tolerability, and the success rates associated with institutional practices. In other words, if you're a really, really busy clinic, trying to manage ovulatory FET cycles is a real problem. That's why everyone's gone to artificial FET cycles. But if the clinician perceives that there is a risk of obstetric loss complications such as preeclampsia, or they're wishing to increase risk like doing double embryo transfers, then that's a clinical decision between them and the patients, but they're suggesting they should be individualized. I'd like to stop here and just go back and say my name's James Stanger. I'm an embryologist with more than 50 years experience. I'm not a medical person, and this information is not medical advice, but hopefully it may help you knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. If you like what I'm doing, subscribe and leave a comment and press like. I'd just like to make finally just a quick word from my other activity, which is running an online EQA program in Andrology and Embryology at fertility.com. And at that point, I'd like to thank you for your time. I know IVF is a personal journey that involves actions and many techniques, ideas, information, and staff, and it helps to understand all aspects of this journey, and I hope this information may be valuable. If you like the information provided, please tell other clients about this service, and please subscribe. And this, my friend, is the end of this video. If I can just work out how to stop it. I'll see you again for another video shortly. Thank you.